growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, it's Dr. Steve Rasner here, and you are tuned in to The Lionhearted Dentist. And let's get it going this week. My email is drrasner@aol.com. Please feel free to write to me. Some of you do quite frequently. And ask me any questions you have regarding the material I discuss each week to try to help you get to the top, which I know you can do. The last several podcasts we've been talking about the skills in case presentation that go towards leading to this rare atmosphere of dental practice that exists today, that allows you to go in weekly and be happy on Monday, not stressed, be looking forward. I know some of you can feel this. I know some of you have had great weeks before. And whether you're an associate or whether you're an actual private practice owner, please be clear that these principles are not a theory. Fee-for-service practice can still exist. It exists in my office every day. It's not easy to get to. But if you tuned in for the first time today, you wouldn't know that I'm in a socioeconomic area of the United States that's far from fee-for-service friendly. It's challenging. I'm not for everybody. I wish I was. And I don't quite understand why we don't even kill it more. I wasn't going to talk about this, but the times today of practicing dentistry are very, very different than they were, say, 20 years ago and before. The patients in my community, for example, had many, many choices in 1980s and 90s of many, many good dentists to go to. And they still exist. But what changed is that corporate dentistry came in. And not that all corporations are bad, but most corporations are corporations because they're there to focus on profitability, probably more than I am, probably more than many of you are. So to do that, they prioritize things that I wouldn't prioritize. A special dental lab, for example, that corporation cut a deal with. Or, I don't know, products that you use in your practice each month. Maybe you cut a deal with a company like that, and maybe you're not getting apples to apples, but you're sure saving a lot of money. Or what type of protocols that you employ on a daily basis. That's why I'm not a fan of corporate dentistry in particular. And look, I understand that it works for many of you, then that's fine. But I know that many of you listening range from dental students to associates, and you need to hear me. Trust me, when you get to be up in your 60s like me, it's kind of hard to understand where you're at in life. I don't know what you guys think. Am I just some over-the-hill guy that is espousing stuff that you think's a theory? Because it's not. I'm not a practice management consultant. I'm not putting them down. We need them. But I'm a live practicing frontline doctor, just like most of you. I know what the battles are every week. The hurts, a patient leaving me that maybe I did my best veneer case on in the last 12 years because their husband doesn't want them to go to an out-of-network dentist anymore. Or they don't want to go to an out-of-network dentist. I have patients, I'm not kidding you with this, that only come to me when they need something real serious, like an implant or things like this. I mean it. Or an interior restorative case. They'll go out of network for that and come back to me because they know that, our work is branded, it's reputable. It's been a long time that we put out that kind of work. Stand behind our work, all the things that go into a successful practice. But there's a lot that leaves. So I know the hurts, I know the upsides. And that's what these podcasts are about, for you to believe and understand that this is real. Maybe it'll be safe next year, 2021, and I'll put out the idea of a 1 or 2 day get together of my podcast followers. I'll make it incredibly affordable where we can come and do it live. That would be cool. I just thinking of this, as you can tell, right on the spot. I don't know what Beth's probably having a heart attack listening to me right now. But anyway, let's get to it. I've been talking a lot about case presentation skills. And in this podcast, I'm going to do the same. And I want to talk about how they resulted in a memorable day and how I literally utilized the skills I'm trying to get you to adopt and how they paid off. Okay? So I'm speaking of a day I had last week. I got there to the office at 9 and I finished at 4 o'clock. I personally saw 4 patients that day. And I had a couple new patients on the side. And we collected over $55,000. Collected. And I didn't see that coming, incidentally. I look at my days and I can kind of get a sense what this day is going to be like. And certainly that kind of day adds to a week. And the week turned out to be amazing as well. And not all my days are remotely like that. But enough of them are in a given year to result in the practice that many of you know about at this point. And so let's take a couple of things that happened that I didn't know were going to happen. I get to my office at 9, a little before. My hygienist comes to me. And one of those patients that you hear me talk about, the nucleus, working on expanding the nucleus of your practice. Go back to last week's podcast on expanding your nucleus, which for summary details basically means even the people that don't buy into what or buy everything into what you recommend still have a good feel. They still trust you. They have a good vibe about your practice. They like coming to you. They just can't do everything that you recommend. And sometimes they can't do any of it. So that creates a good reputation in your community. And those people, in my opinion, are part of this nucleus, and you never know when they're going to spin back off. And some of them fall in and out of treatment that have had treatment by you before. And one of them was in my office that morning in hygiene. I didn't even know she was in hygiene. And I had forgotten, you're going to like this, that we had sent her for ortho. Her initial treatment for me, I want you to get this, is that she had interest in aesthetics and had spaces anteriorly. And she had missing teeth on the mandible posteriorly. And yeah, could I have crowned some of those teeth and closed the spaces, which in some cases I do believe that's appropriate? Yes, I could have, or veneered them. I really thought this patient would best be served by orthodontics. And it may surprise many of you that I don't do any ortho. I have referred my ortho for 40 years. I am not kidding. Just not an interest, a clinical interest to me. It isn't. And this patient came in, and she had her braces on, and she was getting them off in the next few days, based on what I thought. And to be honest with you, I forgot about the case. And my hygienist, so this is part of the protocols of the Lionhearted dentist, you engage and have staff members, whether they're hygienists or assistants or members of the reception front desk team, that believe in the principles and embrace the principles that you set up. So one of the principles are that the hygienists get to the office early enough to review the charts in detail so that they can cliff notes me, if you get me. They can give me a summary. I had no idea. Had she not come into my office before I walked in there, I would have been way, way off. So she reminds me that there was 3 or 4 teeth that needed full coverage crowns before the ortho. And that's why we didn't crown them. And that there was spaces to be addressed. And that was part of the reasons of the ortho. He established enough space between and I wanted to know my opinion at this point if I thought it was sufficient. And that was where we were at. So can you imagine me being presented that, not even knowing who this patient really was on my hygiene. I knew who they are when I walk in the room, and of course, like you, I'm capable of remembering all this, but I had a chance to review her chart. So I walked in, and I want you to hear what I said, because it's part of case presentation skills. The skills of the Lionhearted dentist in the operatory, when you're presenting work, are never about, oh my God, I can get this big case. Oh my God, I have a chance for a giant case. They have to come from a point of authenticity. So that's a very important point to grasp and to follow continually. So I walked in, and here's the first thing I said. Besides the social, how you been doing, how you making out with the corona? I hadn't seen her. Certainly, I didn't remember her, but I hadn't seen her since before the shutdown due to the pandemic. And I said this. I said, listen, Laura, I know you've been through a lot of treatment with your mouth. I mean, you've been in braces for over 2 years. And I know that you had considerable work still to do. And what I want to know is where you're at with it. I mean, do you want to take a break? Because to move forward, there is quite a bit of work, which I'm going to cover with you today. And you have a couple choices. I mean, you're going to eventually have to do some of this. And what you do is going to impact the type of retainer that the orthodontist wants to use and what we're going to do when. And then proceeded about what she needed. And it was way more than I remembered. She did need 4 full coverage crowns. She needed 1 or 2 root canals retreated. They weren't my root canals, by the way. And you'll love this, I refer my retreatments to an endodontist. I only do anterior endo or premolars. It's just me. I do so much surgery. By the way, my surgery course on implants did fill up. That's October 2nd and 3rd. There's still, I think, a space or two for the atraumatic extraction and bone grafting course, live surgeries in my office. You do the actual surgery. You do not need a license in New Jersey. I have that agreement worked out. You need a license in your state, and you're good to go. So reach out to Beth or me if anybody is interested. There's still a little bit of time. That is I think it's like the October 23rd or 4th, the next to the last week of October in New Jersey, if anybody's interested. So no, I don't do endodontics, molar endodontics. So think about this. I'm talking to somebody that's been in treatment for a couple years that needs that. And it's not that it's just she had 2 areas that needed implants, but they both needed GBR. I had to augment horizontal width. So listen to me right now. Part of the Lionhearted dentist is about your skill sets, okay? And where they fit in. So you don't have to be the Lionhearted dentist and encompass all the surgery I do. I certainly believe that your skill set should include taking teeth out atraumatically, excluding wisdom teeth. I don't think wisdom teeth are enough of ROI, return on your investment. And I think there's too much possible comorbidity in those procedures for the fees you get paid. So just not worth it. That's how I feel. This is my mentoring you, my opinion. But every other tooth in the mouth, 2 through 15, second molar. And I know some of you are like freaking out when I'm saying this because you're amazing at taking third molars out. Who cares? It's just not enough return for me and too much risk. That's just how I feel about it. That's me. You should be able to do that. And you should have absolutely some level of surgical and prosthetic implant training. So you can do easy ones in your office. You can make a career. It can severely impact in a good way your income and your variability in what you do each day by just taking the easy ones. But augmenting bone horizontally on a patient that hasn't had teeth for many years, that's not easy. We're talking ramus graft. And I explained that all to her, sincerely. I was totally prepared for this patient who was loaded for bear with work to do. And I could certainly justify continuing right away, which would be the best, because she's just about to finish ortho. And there could be some relapse even with retainers. So it'd be good to get to the point of where we're done. Long story short, I spoke from that point and gave her what I would do if she could do it. And the outcome of that was that she did proceed with a fairly substantial treatment plan for everything I just said. And it was broken down into 2 phases of endodontic retreatment, full coverage crowns and what we were doing, the full coverage crowns, and the bone grafting was included too, but not the actual implant and crown, which will be a phase 2, which will be done, and is important to note this in clarity, right after. Now, one of the things we talked about as a consideration with this patient was doing a 3-unit conventional bridge. She had 2 areas of spaces on her mandible. One was between 2 teeth and one was a posterior saddle. That one obviously is GBR followed by implants. But she had a choice of a conventional bridge on one side as well. So a 3D bridge was shown to her. So that's out of my model box. And that's an important thing to have. This was taking a pretty substantial amount of time. And one of the reasons I'm able to do that unexpectedly is I don't have a heavy schedule on myself. I'm not seeing 7, 8, 9 patients each day. So I have the time. And most of my patients, and certainly the one in the chair, was in the sedation protocol. And maybe this doesn't sound nice, but they don't really know that you're there or not anyway. One of my staff members is there, but the patient has never said in 24 years, where's the doctor, if I was an extra 10 minutes or so and not in a room. So I benefited from that as well. So that was one unexpected case. Then I had a patient, we'll call her Lauren, and she was out of network. Quality patient. You'll like this. This is interesting. And using the skills that I'm trying to share with you. So I go in and I do everything you've heard me talk about. So everything was perfectly in place. And I go in and I meet this patient. And her chief complaint was that her upper left tooth has been symptomatic, sometimes a 7 on a scale of 1 to 10, without her doing anything. And the tooth she was referring to, my opinion, was a tooth with a large amalgam, looked pretty close to the nerve. I could not find a periapical area, but I didn't break it down on the CT scan, to be fair. At that point, I was getting a little pressed for time. But I go in and I share everything with her. Her other important comments during this session together were that she had lost trust in dentists because she had a similar situation on the lower right that she had gone to, and she was very detail-oriented, this patient. And I am cognizant, as you need to be, of all these things. What am I hearing and seeing? Who is this patient? What's her personality? And her personality was, she spoke, she said, well, I went to 3 dentists. I went to my general dentist, I went to an endodontist, and then I went to an oral surgeon. And when I went to the oral surgeon, there was 3 other doctors in the consult as well, which is kind of shocking. And she sounded very factual to me as she described it. And she wasn't really indicting people. She wasn't a troublemaker. She was sharing, and really how she came off. And she was just frustrated. And she ended up, nobody diagnosed a fracture in one of her roots. And she ended up having a crowned, and I don't remember if she had a root canal or not. And she lost it, which is, come on guys, that's the worst story we hear, isn't it? Patient goes through a recommendation of getting a root canal and a crown, and the tooth's always a little bit symptomatic, and they end up losing it down the road. And they tell you that root canals, from then on, they tell you root canals just don't work for them, et cetera, et cetera. So I looked at this patient, I looked at her occlusion, I looked at her muscles, I looked at for wear facets. She had good perio, but copious calculus. It just didn't add up, by the way. I'm trying to give you the picture of this. This is a nice looking woman. From the buccal, you couldn't see much, but her molars and the linguals weren't what I expected. And she had some minor symptoms in other places. Her treatment was some minor restorative on the lower right. The upper left was being referred for a endodontic evaluation. I told her at the least she could expect a crown, and it's pending the outcome of the endodontic evaluation. I'm not sure whether she needed endo or not. I said, if I had to guess, I think you do. And so I have this intact dentition. I have a history of ortho, a missing number 30, 31's in place. So those of you in Europe are talking 4-6 was gone, 4-7 was there. And I didn't recommend at this time that she address the missing molar. I did, as part of her therapy, was some equilibration, occlusal equilibration, and a night guard to protect parafunctional movements in the middle of the night. I told her why. I said, in another patient, I would probably be talking right now about the need or the advantage of putting back your loss number 30, your lower right molar. It doesn't add up here. But you've had a history that sounds compromising, and to do that on you, I just have to tell you that I have to bone graft you. So you have to go through a bone graft. And it doesn't matter to me whether I know it's not that arduous of a procedure, but it is not like getting a veneer. And I just don't think that should be your road right now. What I would do is clean up your mouth, because you need to know that pristine perio, hygiene, gum health is a cornerstone of everybody that comes to me. And it's going to be for you if you come to me. And so she proceeded. And so I just want to tell you this. At the end of this, now this is an out-of-pocket patient who has insurance. And the proposed treatment, depending on the endo, was north of $5,000 or $6,000. So my fees are not low to begin with. And I was totally prepared for her to think about things. She could have done that. And she didn't. In fact, we actually had a very late day that day, so she actually engaged, that one of the hygienists had time to start her quads. And she couldn't thank me more for spending the time that we spent with her. She says, nobody's ever done this before. Nobody's ever taken the time to explain it. And I've been in many, many consultations before. And I was using models and 3D things as I was explaining to her as well. But I can tell you the key to my approach. It was what I'm doing with you right now. It was sincere. It was slow. I wasn't talking fast. I was taking time to listen to her, getting her responses. She had some questions. I was very, very clear about how it's a little odd for me not to replace her molar. And I didn't think that patient should have a 3-unit bridge. And mind you, to do an implant on that patient requires GPR. So that's one surgery, 4 months. It's not a guarantee it's going to grow enough of the bone that I want. I mean, it probably will, but it's a lot to go through. It is. And I don't think that's right for that patient's journey right now. That's my opinion. Because I told her something that came out of my mouth that I think you could use a lot. And that is that I'm managing her oral health care and her individual personality, her individual history at the same time right now. I'm managing both because I got to get her confidence back in dentistry, whether I'm her dentist in 5 years or not. She needs to know, and I said this to her, that good care is out there. And just because you had a bad experience and you ended up losing a tooth, which, by the way, can happen. It just can happen. I mean, Sometimes it's hard to diagnose everything, and I'm saying to you, it amazed me. Just taking that approach with her led to case acceptance. And then the last one I'll share with you was as follows. It was an 80-some-year-old gentleman at the end of my day, presented with a broken tooth to the gum. He had had significant work. He'd been a patient of mine for 5 years. He had implant therapy. He had a beautiful front smile, an aesthetic zone. I think I treated him from premolar to premolar. He didn't have any molars. And in fact, and I do this sometimes to a fault, number 9, which was broken to the gingiva, is a crown that I did for free. It wasn't necessary to absolutely do except for aesthetics. And I will often tell patients the following, which is why I'm telling you this now. I will say, once they accept a treatment plan, I'll say, I want to say one more thing to you. You're going to get everything that we just discussed and possibly more, because it's just how I practice. If I get in there and I think I should have included something else, maybe it's an extra implant to retain a denture. Maybe it's one crown because it'll make the case look so much nicer. And I underestimated that. I'm going to just throw it in. I'm going to do it for you. Because in the long run of things, it'll come back to me. It's the right thing, I think, to do. And in this gentleman's case, aesthetics is generally the 5th arena that I look at for a patient, unless that's why they came to me and told me that. Again, I'm not pushing them on this. So this guy walks in, and he's actually kind of mad that the free crown, because he didn't remember it was free, broke to the gingiva. And I simply told him the truth. Because don't they always say the same thing? He says, I wasn't even doing anything. I think I was eating a piece of soft bread. You've heard that one, right? I said, I get it. I understand it. It wasn't what you're eating. Here's the problem. You don't have any back teeth, and it's a little bit of risk. And, do I give you a partial denture or not? For a gentleman in his early 80s, which is what you were when I met you, that's never worn a partial, it can be a difficult thing to comply with unless I absolutely positively feel you have to have it. I said, look at my teeth. I have all my teeth. If you take out my back teeth, where do you think the forces are going to go? If they increase, will they increase on the rest of my teeth or not? And that's what happened to you. Sometimes it doesn't happen, but it happened to you. And worse is you broke this tooth right at the level of your gum or a little below. There is no way. I can tell you what I used to do. I told the patient this. I used to do intentional root canal and stick a post, and I'm talking real slow to him while he's upright. So that's all part of this, guys. Making eye contact with him. Because remember, I'm talking to a patient, regardless of whether he's right or wrong, that was mad a few minutes ago when he walked in. He's mad. He thought it was the implant crown, first of all. And I had it on an x-ray in front of him, and I pointed out that it wasn't your implant. And the end of the story was he's going to have an implant because the choices were an implant or a flipper. And I would have been fine with either that he did. And that, my friends, is a trust factor outcome on a patient I met 5 years ago. Do you really think, and this is another thing I say to patients because it's true, and I don't think you can say this if you're 40 or practicing in your 30s or maybe even your early 50s. I said, I hope you understand something. I hope you understand that I come to work every day, never with the intention that you guys hoping you'll need something. I hope you don't need anything. You know why? Because when you practice from that heart, there's always work to do. I just don't know how to explain it, but there is. So I don't want you to need anything, but I also don't want to recommend something that will give you an outcome that you'll be upset with down the road. It's your choice. It's my job to educate you. Isn't that the way you think it should be? And I talk just like that. And this guy was kind of grumpy, to be honest with you. I don't know how that was going to end. And it ended quite well. And I don't want to go into the rest of them, ended up being just a spectacular day and a feel-good day, which to me is a giant part of it as well. So I don't know, guys. Please write to me. I've been spending so much time in the last 3 to 4 podcasts on this centered case presentation arena that is so vital to our outcomes, to what you do next Monday, next week. Does that have anything to do with every case presentation you gave in the last couple weeks? And when I say case presentation, they're not always new patients. They could be returning patients. Speak from your heart. Speak as if money is the last thing that you care about. Speak from what you think that particular patient should do and benefit based on what your eyes see with the radiographs and clinically, and given a thought, based on what the patient's history is and what they want. Talk slowly, look them in the eye, and speak the truth. That's it. And if you go through periods where nobody accepts treatment, it's still the only way to practice. Because if you do that in the long run, you're going to stay busy. That's not a philosophy. That's real fact, real life from a fellow clinician of many, many years that's enjoyed that. You know, the week before this week wasn't very good because I didn't have enough new patients. And so I'm working on my marketing right now for that, maybe changing up my marketing a little bit. Anyway, guys, I hope this helped. Reach out to me. I'll continue to hammer all this from the different perspectives. You know, I've been much more technical when I talk about case presentation with you in the past. And if you go back to those podcasts, you'll see I break down my exams into 5 arenas that I'm not going to cover right now that I've covered very thoroughly in the past. And I don't deviate from that. That is the approach I take, and it leads me to an easy place to make a recommendation. So have a great week. Don't give up this fight. It is worth the fight. The feel-goodness of putting it all together, something you worked hard to do, to me is very, very worth it. I know to many of you is. Have a great weekend. See you next week on the Lionhearted Dentist.